Yeah, so it's getting set up. It will just take about 10 seconds. Okay, so let's get started. It's a pleasure to have Professor Gautam Menon from Ashoka University. My apologies for the delay. There was a brief goof up in the Zoom setup. I can see that some of you have joined here on Zoom, and I can see many more people on YouTube Live. I hope that all of you can hear me. For people who are on YouTube Live, I would request you to... Yeah. Yeah. So, yeah. So please... So for people on YouTube, please put your post your questions in chat, and I will transfer them here on Zoom. So Gautam is going to talk to us about COVID-19 in India, a perspective from models. We had an excellent talk by him in the ISRC symposium, but that was a brief one. We hope to see a lot more details today. So Gautam, over to you.
Thank you, Jasjeet. I hope you can see my screen, my shared screen clearly. Okay, good. So let me start by thanking Aisar Mahali for this invitation to speak here. And what I want to tell you a little bit is about COVID-19 in India, what we understand about its spread, and then go on to discuss what models are and what models can predict for you when you think about COVID-19. So let me first discuss the current state of COVID-19, not just in India, but across the world, what we understand now to be the case for COVID-19. If you look at a map of the world and you color each country according to the number of cases that it has had per million of its population, some things immediately stand out. First of all, the US, the continental United States, is very darkly colored on this, indicative of the large number of cases that it's seen. You can see Italy stand out, you can see Spain stand out, you can see the UK stand out, Sweden as well. You can see Iran. India is in a somewhat lighter shade here because we just simply have not seen the number of cases per unit per million of our population that these other countries have. And of course, you should take this with a pinch of salt because how many confirmed cases you have depends upon how much you test. And certainly in India, the feeling is that we are testing a smaller number than the actual number of cases in our population. So that's one thing to consider, that we may actually be rightfully a darker shade than the one that we're actually shown in on this map. If you look at the numbers themselves, these numbers are, for the US, you have a number which is something like 1.3 million confirmed cases. For the UK, this number is around 230,000 as of yesterday. For India, the number is about 70,000 as of today, as of this morning. If you ask, how are these numbers of confirmed cases increasing, which is really the important question now. It's less a question of, are they, what is the absolute value of that number, but what is the trend in that number? That's what we should be looking out for. And over here, you can see that this is a line that I've shown. This is a graph that gives you the number of confirmed cases as a function of the date on the x-axis. And over here, you can see that the last points, let's say the week of data, the last week to 10 days of data, is fit fairly well with a straight line. So the number of confirmed cases is rising roughly linearly. And the doubling time currently is somewhere between 10 and 14 days. 14 days according to some people, 12 days according to some other people. That depends upon the details of how exactly you average those points over the last 3 or 4 days in order to get somewhat more smoother data. As I said, we have about 70,000 cases as of May 11th. From here, if you looked at the doubling time of the total confirmed cases over a much smaller unit, you find that we're actually at a smaller doubling time with respect to either the United States or the United Kingdom. And that's interesting because our doubling times, in a sense, the larger your doubling time is, the more control you've had over the disease. And the UK and the US, even though they did have very large epidemics, seem to be moving into a phase where the doubling time is actually increasing over a fair bit. That's a good thing for them. If you asked about the number of cases, we've recorded over 10,000 new cases over the last 3 days. And May 11th saw the highest number of cases, the highest daily increase at 4,213. So this is an epidemic that is showing no sign of peaking and returning. So the ideal way, if you would like an epidemic to behave in the way that suggests that you're seeing a peak and then a decline, you would expect the number of new cases to go down, and that isn't happening. If you look at what's called the case fatality rate, which is the number of deaths divided by the number of cases, that number for India is actually fairly small. So far more of the confirmed cases that we are seeing are surviving, as opposed to countries like Italy and the United Kingdom, which are much larger. So Italy and the United Kingdom are seeing numbers as of today of about 14%, 15%. The Indian number is around 3%. The US number is still somewhat higher than that at about 6%. So that's interesting because a low case fatality ratio is certainly an indicator of the fact that the disease has not hit our population as strongly as it might have. But then there is the question, are you counting the deaths correctly? Are you getting all of them? Are you accounting for every possible death, even though they may have occurred outside a hospital setting where you're bound to record it anyway? If you look at the rates of testing, which relates to the previous question, how many cases do you actually have? Our rates of testing are very low compared to pretty much any of the major countries of the West. The United States is currently testing on average between about 25 and 30 people per 1,000 people. Canada has a larger number than that. The United Kingdom is looking at a number somewhere between 15 and 20. And for India, the number is somewhere around 1 to 2. So 1 to 2 people are being tested effectively per 1,000 people. In order to see the number of cases saturate, you would actually have to ramp up the testing in order to find out, if I increase my testing and I pull more and more people who are positive with COVID-19 into my net, what can I say about them? What can I say about the number of deaths within that particular group? Right now, I don't know. There is uncertainty both about the number of deaths, because not every death is recorded, and there is uncertainty about the number of cases as well. Let's dig into this data at a little more granular level and ask similar questions. If again, you plotted on the map of India and plotted different colors depending upon how many cases that they were confirming. And the darker colors here, the red light color is the larger number of cases. The light blues are a smaller number of cases, and yellows are somewhere in between. What stands out immediately is Maharashtra is red, and Tamil Nadu and Gujarat are both tending towards red. They're somewhere in the middle. They're sort of yellowish at the moment. A lot of the rest of India is somewhere between the extreme blue, which will be a relatively small number of cases, and shades in between there and the yellow. So that immediately stands out that the places to worry about on this map are really the states of Maharashtra. Tamil Nadu has seen an increase in cases over the last week or so, typically tied to one particular event that happened, the Koyambedu market. And Gujarat, the number of cases have been increasing steadily over the past week or so. At an even more granular level, you can see even more detail emerge. First of all, apart from Bombay, Pune, and a bunch of districts clustered around there, Delhi stands out as another place where cases are increasing. Parts of Rajasthan, Gujarat certainly, parts of Tamil Nadu, mainly centered around Chennai. And Kerala has seen a slight resurgence over the last few days as someone from in Chennai went back into Kerala. But apart from that, there is a large area in the center of India, states of Madhya Pradesh, of Jharkhand, and so on, which seem to be relatively low in the number of cases compared to the rest of the country. And there is this question, of course, of are we testing enough in these regions as well, as much as we're paying attention to the large urban regions inside our country. If you look at the little bit of Indian data that has actually come out and has been systematized in some way, what you will see is that the distribution of COVID patients is very asymmetric by gender. It's the elderly are most at risk, and pre-existing conditions are also at risk. All of this tallies with what we know about COVID-19 from other countries as well. So none of this is particularly surprising. The distinction between male and female patients is actually fairly large in India. And the numbers for male patients are about 854 to 307 for women. So that's between a 30-70 split, or possibly even larger than that. And that's interesting because this is not really a feature of a lot of other countries. There, the differential is somewhat smaller. It's 55-45% or 60-40%. And that's again, one has to ask whether there are social factors involved in making that behavior that way. So let's get to the question of why we should model in the first place. And I want to provide a little bit of explanation here. And the real reason is that modeling tells you what to expect. What should you expect to see in the next week or 2 weeks or 3 weeks? And what gives you the ability to plan ahead for any eventuality in those 2 weeks or 3 weeks? The other very important thing that a model can do is enable you to compare what are called non-pharmaceutical interventions. These are interventions that do not have to do with drugs or vaccines that specifically address the disease, but with things like quarantining, lockdowns, selective lockdowns, staggered lockdowns, allowing people to go back to work, some of them to go back to work in certain occupations, etc. You can test the relative effectiveness of all of these measures against each other using modeling. The final reason is, of course, that you understand diseases better if you have a good model for that. The better your model is, the more able you are to understand what the progress of the disease might be, and to ask more deeper and more fundamental questions about how it might affect your population. So what are the questions you can ask about an epidemic? First of all, the most general question is, you have a large population, how is the disease affecting the population? This is the field of epidemiology, and what you would like to predict is a proportion with ill health, a proportion that changes with time, and how does that behave as a function of time? The most profound and important way of thinking about this comes from two British scientists, Kermack and McKendrick, who came up with the basic ideas behind this about 90 years ago. And these, in a sense, have been very fundamental to the field. They define the language with which we think about infectious diseases. So the idea there is very simple. You just imagine that you break up your population into 3 parts, or they're technically called compartments. One is a susceptible compartment into which you put all the people who have not contracted the disease. The second is an infected compartment in which you put all the people who are infected with the disease currently. And the third is a recovered compartment in which you put all the people who have recovered from the disease. Initially, you might have everybody in the susceptible compartment, especially for a disease that humanity has not seen before. But as they become infected one by one, they move from the susceptible to the infected compartment. And from there, they recover to the recovered compartment. So that's a sequence of arrows in which someone who's susceptible becomes someone who's infected, becomes someone who's recovered. And that's the process by which you move between these compartments, leading to a change in the numbers within these compartments. As people leave the susceptible compartment, the numbers in the susceptible compartment will go down, and the numbers in the infected compartment will increase. Similarly, as the numbers in the infected compartment go down, they move to the recovered compartment, the numbers in the infected compartment will decrease. The twist here, as was realized by Kermack and McKendrick, is the fact that the infected compartment affects the rate at which susceptibles become infected, because you cannot go from susceptible to infected unless you are in the presence of someone who's already infected. So that's the key here, that the infected people exert an influence. So that's why it's a dotted line. It's not a movement from the infected to the susceptible compartment, but an influence that the infected exerts on the susceptible compartment in order to make people infected. That's the logic behind these models. And from here, it's possible to see that you can write this in a mathematical form, and these famous equations that you see to the right here are really an encapsulation of the same ideas that I told you about the movement from the susceptible to the infected to the recovered compartments. And these equations will tell you how these numbers change with time. Here's a classic and possibly the most famous example of the application of these equations. So this is to the plague epidemic in Bombay in 1906. And this is the original paper of Kermack and McKendrick, in which they plotted the results of their theory against the actual data. So the results of the theory are the white circles with a line through them, and the black dots there are the results from those who were admitted at any particular time. So this is the x-axis is the time in weeks over which the epidemic went to a maximum and then came down. And the y-axis is the number of infected people within that week. So it's what is called an incidence, a weekly incidence of new numbers of cases. You can see that this is actually a very good fit to the data, given how difficult it is to find and interpret epidemiological data. The fact that it roughly tallies, in fact, it tallies pretty well both in the tails on both sides, is actually an indication that epidemiological theories do work very well when they're understood to work. This is how the susceptible, the infected, and the recovered compartments look like. The infected is the line in the bottom, the one that goes up and then comes down again. And that's what should be compared to the little inset, which is the data from the plague epidemic that I was telling you about. The susceptibles are very large in the beginning, and then they come down and saturate to some value. The number of recovered goes up and saturates. If I add the number of susceptible, infected, and recovered at any time, they will equal the same number, because no one dies and no one is born. That's the assumption behind this particularly simple set of models, although you can improve upon this in better models. The questions that you might want to ask is, will the disease spread? how many people will be infected, how many people might die. All of these questions, the answers to all of these questions depends upon one fundamental object in this theory. That's called the basic reproductive ratio. It's sometimes referred to as R0 or R0, and it has a very simple interpretation. That interpretation is the following. Given that there is one sick person, how many people do they manage to infect in a completely susceptible population? So that number for Ebola is about 2, which means on average, one Ebola patient will infect 2 people. For swine flu, the number is about 2. For swine flu patient, they will infect 2. For HIV, the number is 4, which means for one HIV patient, 4 people will be infected. For smallpox, it's 7. For measles, which is highly contagious, the number is 18. So where does our own disease, COVID-19, fit into this? The number for COVID-19 is somewhere between 2 and 2.5 for the basic reproductive ratio. It's been argued to be 2.2 to 2.4 in some parts of the literature. Some numbers have been very large. Some numbers have been around 5 to 7 for COVID-19. And there are other people who suggest that the number for India is a smaller number, maybe around 1.2 to 1.5. And this is a number that one can really understand only after the dust settles and after we've made account for how many cases there actually are, as opposed to the cases that we're actually testing. So as I said, for the coronavirus, R0 is somewhere between 2 and 3, but R0 really is a different object from what is R currently. R0 is the value that it takes, that the reproductive ratio takes at the beginning of the epidemic. After you impose various types of interventions, for example, vaccination, whether you put in the non-pharmaceutical interventions such as lockdowns and so on, R0 will go. Because R0 is influenced by 2 things. One is purely biological factors, how easy it is to transmit the disease. And the second is the nature of contacts between people. How many people do I contact and how productive are these contacts? Given a single contact, how likely is it that I will transfer the disease from someone who's infected to someone who is susceptible to the disease? So the current guess for the number is, with the lockdown, it's somewhere between 1 and 1.5. And currently it seems to be around 1.5 from our own calculations. One step ahead of the SIR model is something called the SEIR model. And this is a term that you will hear a lot in the discussions of the COVID-19 pandemic. So that in addition to a susceptible, infected, and recovered compartment, you have an additional compartment called an exposed compartment. So that's when someone has been exposed to the disease, is in the process of falling ill, but has not managed to manifest symptoms yet. So at that stage, at the exposed stage, they're asymptomatic. Later, they become symptomatic for the disease. And this is one way of thinking about the disease, of how the disease might unfold. And the interesting fact about COVID-19 is that even in the exposed state, where the virus is just building up in you, it's possible for you to infect someone. So there is a certain epidemiological quantity called the serial interval, which is the time interval between a primary case patient having the onset of symptoms and a secondary case patient having the onset of symptoms. And the fact is that here is the plot of that. This is the plot of the number of patients as a function of the serial interval 1, 0, 1, 2, 3, 4, 5, 6, etc. And you can see that this has a peak at about 4 to 5 days, which is what we believe the number to be roughly. But it also has a peak to the negative end. So that means that even before you exhibit symptoms, it's possible for you to infect someone else. And that's the interesting feature of COVID-19. That is not really a feature of most other diseases that we know of. So this is a talk about models. So let me tell you a little bit about a few models. The main model that I will tell you about is a model that we ourselves have developed. It's called the INSISIM model. And this is developed with a modeling group at the INSI called the Indian Scientists Response to COVID-19. So this is a group of about 600 scientists, people. In addition to scientists, there are many graphic artists, there are journalists, there are people interested in the public communication of science, there are some lay people as well. And this group was formed about 2 months ago, 2.5 months ago, to look at COVID-19 from a scientific point of view, in order also to be able to communicate to the public what it is that we understood about the disease and what is it that they should know in terms of busting hoaxes, in terms of preparing themselves for what might come. So one part of this work was to create a modeling group that would look and examine models for the disease and try to come up with what they would think would be the best model for COVID-19 in India. So this is the web page of the ISRC, or the Indian Scientists Response to COVID-19. And there are 2, what I will tell you about on that web page, and will shortly be written up for publication as well. So I can encourage you to go and have a look at these reports in order to understand in a little more detail what I will be telling you about. There's also a dashboard on that web page, so you can put in your own numbers for how fast you think, give for the reproductive ratio that tells you how fast the disease is going to spread between persons and persons. You can choose to model a city. You can choose to model a state of India. You can try all of this and then ask, what is it that you understand from this particular scenario? Okay. So there is a dashboard that is available, which you can use. What we set out to do was that we wanted to provide a state-of-the-art compartmental model for COVID-19. I will tell you what a compartmental model is. The compartmental model is really the same as the SIR model, which I refer to as compartments. We wanted to provide something that could be used to model the spread of COVID-19 in India at the level of states and even at the level of districts, which is as granular as you can get at the moment. The other aim was to try to synthesize data from multiple places to provide a benchmark set of rates that other people could use in order to model COVID-19 in India and its peculiarities in India with respect to other places. We wanted to include demographics, the differences in population between states, the age structure within these states, as well as migrations within these states. We wanted to look at non-pharmaceutical interventions and evaluate which was better than which other intervention, provide the online tool, update it easily, and make anything that we changed with the code, make it transparent. So the idea here is to replace a simple SEIR model by something that represents a little more accurately the true state by which a patient goes through, the true progression of the disease through multiple patients. So if you look at the map below, this is the model that was proposed by Mordecai at Stanford, you can see that there are multiple categories of patients. There is an asymptomatic category of patients, someone who falls ill with COVID-19 after being infected, who goes through a period in which they're exposed, a period in which they are asymptomatic completely. That is, they barely show any symptoms of the disease, thereupon they recover. Even though they are asymptomatic, they show no symptoms, they can infect other people. The mildly symptomatic goes from being exposed to pre-symptomatic, in which case they can begin to infect people, to mildly symptomatic, and from there to the recovered state. The severely symptomatic patient goes from being exposed to pre-symptomatic to being severely symptomatic, and then passes through hospital, and then finally to a stage where they recover from the disease. The last category is for the severely or the critically affected people who will go from being exposed to pre-symptomatic to severely symptomatic to hospitalized. And from there, they can either choose, it can either happen that they die or they recover. And the critical patients, a fraction of critical patients are those, of course, who will need more intensive care within a hospital. They will need ICU units and they potentially will need oxygen. They will need ventilators. This is a complicated description of the model in terms of these different compartments. Each of these little boxes is a compartment: the susceptible, exposed, pre-symptomatic, asymptomatic, mildly symptomatic, severely symptomatic, the hospital compartment, the recovered compartment, and the death compartment. And there are multiple parameters, multiple Greek symbols in here, which tell you how you branch from one compartment to the other, the rate at which you move from a compartment to the other. And all of these rates and numbers are specified in terms of the properties of the disease and whatever we know about the disease. I just want to draw your attention to one particular quantity here. Beta is a fundamental rate that tells you how fast you move from the susceptible to the exposed compartment on being infected. The C parameters, the CS, the CP, the CA, and the CM are parameters that tell you what is the nature of the influence of infected people upon susceptible people that makes them go into the exposed compartment. If you switch those C's off completely, then the infected people would not be able to infect the susceptible people. That would correspond to a situation of perfect quarantine, where the moment anyone showed that anyone had a trace of virus in their system, you remove them from the population and prevented them from infecting anybody else. In general, these numbers are not zero. They are somewhere, if they were 1, that would represent the true scale of transmission between the infected people and the susceptible people. By modulating these, we can hope to impose certain types of interventions, which I will tell you about. So the C's in this particular picture represent what is called the intensity of contacts, the nature of contacts between people who are infected and people who are susceptible. Tuning C's we interpret as being a non-pharmaceutical intervention. It's a product of the C's and the beta that determine the R, the reproductive ratio. So if you just reduced R, that would be equivalent to a lockdown. But you can see that you can do it by changing beta, as well as you could change it by changing the C's. So reducing the C's is what we interpret as really your testing regime, which leads to quarantining and testing together. If you manage to if you have a patient who is test positive, by quarantining them, you're reducing the intensity of the C's, you're reducing the contact of them with the general population, which contains susceptible people. There is a more complicated set of equations which are described on the lower right-hand side. The parameters are described on the top left. You can generalize this in multiple ways. You can generalize to having each compartment segregated or separated by age. So you account for the ages 0 to 10 separately, 10 to 20 separately, 20 to 30 separately, all the way down, because you know that people who are older are at more risk of falling ill with COVID-19. You can also put in additional structure that relates to the probability that someone aged between 40 and 50 is a diabetic or has cardiovascular disease, all of which predisposes them to a bad outcome if they're infected with COVID-19. Right now, the model looks at states, but we're going to extend it to look at districts as well. So this is called a meta-population model, because you imagine each of these states as combining together as populations to form one large meta-population. We put in age structuring in the model. We distinguish between these different age brackets. We allow for migration between cities, between states, between any part of it to any other part. We also account for healthcare accessibility. We account for that fraction of patients who are not able to go to hospital, even though they're severely ill. So they will progress directly to being cured or to dying at a somewhat larger rate, because these are patients with whom the public health system cannot intervene. And these typically happen in states where the public health system is weak rather than strong. We can also put in quantities that measure that in terms of health system or healthcare metrics that can differ from state to state. We can look at models for cities. So there we have a model for about 318 cities that are connected through rail and various transport networks. And you can see migrations between these cities. The models we consider for now are what are called balanced models. The balanced migration is no net population change between these cities. And we can look at that. We start with values that we assume for exposed, pre-symptomatic, and asymptomatic categories. These are very hard to estimate. And just knowing the number who have tested positive won't help you sufficiently. What you need to do is to be able to choose that range based on the positive cases that you're seeing. We take the reproductive ratio, the beta parameter that we have from statistical models, and these are models that are now accepted in the community. As I said, the best models that we have now suggest that are not for India is about 1.55. Whereas we can also do it statewide. The number of Maharashtra as of the 24th of April was 1.54. Now that number is larger because the disease is spreading somewhat faster in Maharashtra than elsewhere. What do we learn from this model once we start it off? We can take, so what I'm going to do is to take numbers appropriate for Maharashtra and try to run this and see what do we predict. The first thing that we could do is imagine that there was no intervention at all. We did not intervene at all. There were no pharmaceutical interventions, no vaccines, etc. And then we can ask, as I change the number of people in my starting parameter, the number of exposed, the number of pre-symptomatic and asymptomatic, let me not change them by very much. Let me change them somewhere between 10 and 100, and then ask what is the progression of the epidemic. The thing about epidemics is that you can start very small. You can start with 2 or 3 or 4 people, but the peak value of the epidemic is independent of the number with which you start out with. What happens with smaller numbers versus larger numbers is that you just shift the peak of the epidemic by a certain amount, but the value at that peak is always the same. You see that in this data as well, where we look at numbers of infected. This is the state of Maharashtra, where the number of infected goes to about 200 lakhs in this particular case, and the number of hospitalized is in the number of somewhere between 4 and 5 lakhs. If you decrease the infectivity by changing the R0 parameter or the beta parameter, you can achieve what is called flattening the peak. You reduce the number of infected, reduce the number of hospitalized, and you spread the infections over a longer period. So that again, one can do within this model by changing beta through some sort of intervention. We're not specifying here, we're just treating it as a number which can change in some way. And then see that that has measurable consequences on the number of infected and the number who are hospitalized. What we did really was to look in some detail at this whole question of what does testing and quarantining do? Imagine that you had the ability to test an increasingly large number of the population every day, every week, every month. Could you then bring down the total number of infected people and the total number of hospitalizations if you could do that? Our conclusion was that yes, you could. And it happened, you could do this actually very strongly, the better and the more stringent your testing and quarantining regime was. Many people have been saying that it's very crucial to do testing and quarantining to have an idea of the number of people who are positive at any given time and to be able to isolate them from the general population so that they cannot infect the general population. Here is an example where we can implement that in the model and actually see what difference it makes. So the way the model is structured is to say that we can imagine ramping it up from no testing at all to essentially perfect testing over a period of 200 days or 300 days or 400 days, and examine the effects of this ramp up on the total number of infections. Then as you can see, the dark shaded region there is without the intervention. You can see that the lines inside have reduced the number of infected over somewhere between 20 to 80 lakhs from the initial 200 lakhs. And the number of hospitalized is now somewhere in the range of between 1 and 2 lakhs in that case. What happens with a lockdown? With a lockdown and no other interventions, all you do is delay the peak. You will still have the same peak because there will still be people with some disease at the end of the lockdown, and they will communicate it to people, to susceptible people who surround them, and that will increase. Pulling them out of the population does reduce the possibility that you will spread the disease, certainly. But even if you have a small number to start out with in the beginning, that's enough to give you back. So all lockdowns do is really shift the peak. If you accompany lockdowns with testing and quarantining, preferably started before the lockdown and continuing throughout the lockdown and after the lockdown, you can again reduce that hugely. And now you can see that the number of infected have now gone from somewhere from earlier between about 2 to 80 lakhs to now about 30 lakhs. And the number of hospitalized has gone down to sub 1 lakh, with combining lockdown with a quarantine and testing regime. You can imagine more clever ways of doing the lockdown. You can imagine a lockdown in which you pulsed it so that you lockdown, you opened up, lockdown, opened up, lockdown, opened up through some schedule. For example, a 7-day lockdown, 5-day workday would be one way of doing it. You could even imagine lockdowns in which you impose what is called a light switch strategy. That the moment you saw case numbers increasing above 100, above, let's say 100 or 500 new cases per day, then you immediately impose a lockdown, and you would maintain that lockdown till the total number went to a much smaller number, let's say 10 or 15 per day, which you can cope with. Even there, testing and quarantining does make a difference if added to what you would do in the presence of a lockdown, either a staggered lockdown or a regular lockdown. As I said, the advantage with this model is that you can do it at any scale. You can do it at an all India scale, you can do it at a state scale, you can do it at a city scale. Here's an example of a city scale model for Chennai, with the population of Chennai, where you look at the no intervention case and the quarantine testing case, where the quarantine testing is spread over a year. So the numbers without intervention is something like 175,000 people who are hospitalized in Chennai. The number with quarantine testing, even a fairly mild form of quarantine testing, where you imagine the ability to test your entire population evolving over an entire year, still brings that down from 175,000 to a number like a small, so at the worst case, that would be something like 50,000. At the smaller case, depending upon the number of infected people you had to start out with, that number could be as small as 10,000 or less. So here, adding the number of people being infected in the beginning does matter. It's not just a shift of the curve, but it also tells you that if you hike up your quarantine testing, if you have a smaller number of people who are infected to start out with, that is a better situation and a much more controllable situation. As you reduce the period of quarantine testing, there's a very drastic decrease in the number who needs to be hospitalized. So if you could manage to increase your quarantine testing abilities over a period of about 4 months, with 120 days, then in that case, your hospitalized population would go down to about 400 to 500, which is a huge difference from what it was initially. The other thing that we could do with models is to look at a bunch of different strategies for emerging from lockdowns. So that's a question that everyone is discussing nowadays. What happens at the end of the lockdown? And as I said, at the end of the lockdown, if you allow things to go back to normal, then you will see your number of cases begin to rise again. That's almost guaranteed for you. But you can imagine sending people back to work in a staggered way. For example, you could imagine sending them back to work for 2 days, then taking a break for 4 days, 2 days, 4 days, 2 days, 4 days, and doing this synchronously for the entire population. The other way you could do it is to divide your population into 3 parts and have 1/3 go for the first 2 days, then take a break for 4 days. The second third go for the next 2 days, take a break for 4 days. And the third of them go for the next 2 days and take a break for 4 days. That way, everyone works. Everyone works over a 6-day period, but everyone also has time off during which they're under lockdown type of conditions. Which is better? So this is something that we've looked at again here. And it turns out that the second option, what we call the asynchronous lockdown, where you don't have everyone going to work at the same time and everyone on lockdown at the same time, is apparently a better strategy. If you combine an asynchronous lockdown with fairly stringent quarantining and testing, this is probably the best situation that you can possibly get, with hospitalized cases somewhere between 100 to 500. Of course, it depends upon the stringency with which you can impose quarantining and testing. If you can only do it over a year, year and a half, these numbers will become larger. But this is still a sensible option for getting people back to work while keeping your testing and quarantining regime strong. So this idea of using this, of staggering working and lockdown, etc., is due to an Israeli group by Yuri Alon. What we've done is look at this in the context of a large number of choices for working and taking a break, as well as examined it in the Indian context with numbers appropriate to India. What we now have with this model is a district level model. It's soon to be online. We have age stratification, we have risk stratification. And what we're working now on is the ability to tune accurate inputs to this. The district level data is somewhat spotty, so we're trying to improve our understanding of what happens at the level of individual districts so that we can get better inputs to put into the model. There are a couple of other approaches to this, and I just want to tell you about one that our own group has been working on. So that is an approach called an agent-based model. The first models that I told you about are like the first pass models for any disease. What you want to do is to write down a compartmental epidemiological model that describes the course of the disease as best as you understand it based upon what causes it, how it's transmitted from person to person. And these are quick ways of understanding what are the numbers, what is the rough sense of the numbers, and what might happen with one pharmaceutical intervention, one non-pharmaceutical intervention vis-a-vis another. The agent-based models are far more granular models. Essentially what they do is they try to create a synthetic city with a synthetic population and put in as much detail as you know about the city into that synthetic population and synthetic description of the city. For Bombay, for example, you can see the picture here is for Bangalore on the left-hand side. And you can create a synthetic population for Bangalore with somewhere between 1 and 10 million inhabitants. You can choose to be completely faithful to the actual number, the census number of inhabitants of Bangalore, and put them in. You need to figure out where people stay. So where are densities of population largest versus smallest, where people go to work, describe their contacts at work and at home, describe other things that they might do. For example, go to a park, drive somewhere, take public transport, etc. Put all of these details into a model and then ask about the effects of different interventions. So there's a very nice model right now from Rajesh Sundaresan at ISC and Sandeep Juneja at TIFR who've been looking at the Bombay data. And they've generated plots that look like those on the right, where you can have full lockdown, controls in the workplace, partial lockdown, etc., etc. And really looking at the same question of how do you send people back to work in an effective manner, ensuring that the disease doesn't spread. With a company called ThoughtWorks in Pune, I myself have been working on a type of model like this with somewhat larger focus. While we started with Bombay as an example of what it is that we can do, we are trying to write down, we are trying to develop a model that will look at the whole Indian population of about 1.38 billion. And the idea is to not only have this as a tool for COVID-19, but to have this as a tool for infectious disease research, for public health research, as well as for other types of social science research that might be useful in the future. Okay, for the larger communities, we're going to work on this. So part of this is a very intensive drive to understand what is a good synthetic population for India. How do we map different regions and their populations within India, workplaces, farming, rural, non-rural, etc. Can we use economic and social science input to refine our understanding of what should go into such a model? The other types of models for disease spread, again, there are a bunch of others. Here's an example of something else that we've done, looking at a model for disease spread in the Vellore area, where we have collaborators with some data about what might happen in a particular study population. So this is a little movie that imagines a bunch of individuals moving back and forth between home and workspace. One or two of them are infected, and that infection grows. You can have people going to hospital, people coming back from hospital, and thus estimate what are the levels of people who are moving from hospital back to home, etc. So this is a visualization of the model with not very large numbers of agents, but we can do this with much large numbers. So the sort of state of the art for that particular model is to do 130,000 agents, which is the number inside the population. What we've been interested in is looking at lockdown types of situations. So if you have two exposed people initially to nucleate, to start off the infection, what happens? You can imagine a very stringent lockdown in which everyone is confined to the home, and anyone who turns symptomatic, it is immediately pulled out, and everybody in that house is tested. If anyone tests positive, they are pulled out as well, so that they cannot affect the population. However, no lockdown, as you know, is ever 100% effective. So you can imagine softening the lockdown a little bit by letting the adults stay at home, but allowing the kids to play in the street that is most adjacent to their house. You can ask, what does that do? It's hard to confine children into small confined spaces in dense areas for any length of time. So you might imagine that parents will willy-nilly be forced to allow children to run out, but tell them that they cannot run too far, they have to stay within the same street. The other urges that we might have, certainly apart from going to markets, for shopping, etc., is places of worship. So you can imagine that there are places of worship associated with this entire population, that there are 3 types of places of worship. There are certain numbers per unit of the population, and people worship there thrice, some fraction of the population worships there thrice a week. You can imagine children having to go back to school while their parents remain quarantined. And then you can ask, what happens in that particular case? So you can try many different scenarios. These are stochastic models, so they will not run the same way every time you run them. So here's an example of stochastic trajectories, which are the gray trajectories that you see at the back, and the average of these, which are these darker lines that you see through these. So let me just summarize very quickly. With just 2 initial exposed people with a perfect lockdown, the infection dies down very fast. At most, people who stay within the same house. Once you allow children to play in the streets, that number increases because now you have the potential of infecting everybody on the street. Child A infects child B goes back to another house, infects everybody in that house. And all of this is, as I said, with reporting of the symptomatics. So every symptomatic person is immediately quarantined and removed from that particular locality. So that number goes from 12 to about 300. If you include places of worship, that number goes to about 3,000. Children come back, infected parents go to places of worship where they see a larger number of people, somewhere between 100 and 200 people at that place of worship. And then this spreads more effectively. Once you allow children to go to school, you now allow people from many different localities to come to the same school. So a child from this locality who's infected can go and infect another child from another locality. And that's how you see the spread increasing. So the spread is always an outward spread. It's within the house, within the street, within the local place of worship that defines a bunch of villages, and then further beyond that to this whole study area that we're looking at. So we can gain intuition for multiple ways in which the disease can spread using methodologies like this. And that's why I think they're interesting. Let me talk in the last few minutes about, before going on to tell you about what might be happening in the future, is a little bit about the responsibility to communicate responsibly. And some of you may have seen this picture reproduced. This is the Joint Secretary's press conference in the Ministry of Health and Family Welfare on 11th April, where he projects different scenarios for this and says that the nationwide lockdown containment measures currently should lead to a relatively small number of confirmed cases and a very slow increase in that number. And these seem to be really just simple exponential fits to some set of numbers there. There's really no epidemiological understanding of what might be behind this. And this is an even more surprising picture. This is by V.K. Paul of Niti Aayog at a press conference on the 24th of April, where you see a fit to the data that goes up, then comes down again. In fact, it goes down to 0 on the 16th of May, which is just 4 days away from now. The epidemic right now is peaking, is becoming higher and higher in terms of the total number of cases. The new cumulative cases is really increasing at a number of about 3,000 to 4,000 per day. So it's really nowhere near that peak and coming down. This is just not true at all. And it's surprising that a figure like this was produced as part of an official government briefing, because there is really no reason, no epidemiological reason to believe any figure like that at all. What happens next is what I'd like to finish up with. And as I said, you have an initial peak, which represents a standard epidemic where you don't control it at all. You can suppress that peak by introducing various types of physical distancing, various types of non-pharmaceutical interventions, etc. What that does is flatten the curve, push it down and push it out to the right-hand side. As long as there are infected people in the population, or as long as you don't control for people from the population, even if you have a completely susceptible population where everyone has been cured, that situation is always unstable to people from outside coming to that particular location. And that will lead to the rise of the epidemic. And so that's a second wave and a third wave, multiple waves of the population as the infection runs through the population. So whenever you lift a lockdown, there is always the risk of resurgence, because people go back to a situation where the effective R is higher than it was before the lockdown. Let me just finish with this particular picture. And this shows daily new cases. So there are no numbers on the Y and the X-axis, because the point I want to make is a purely qualitative point. This is the daily number of daily new cases of COVID-19 computed over a 10-day average for a bunch of countries in the top row: Australia, Austria, Cambodia, China, Croatia, etc. So you can see that all of them share the same ability, the same property of going up and then coming down again. So by the time you move forward in time, so this is around the end of April, this graph has been made, you can see that these countries are seeing fewer and fewer, in fact, pretty much 0 new cases per day. Look on the left-hand side, that's a country, Turkey, which has seen a peak, has seen a definite decrease from that peak, but is now having difficulty pushing that peak number down to 0. Where we are is a picture on the right-hand side, the right-hand bottom corner. And that's the number of cases which seems to be increasing. We're nowhere near seeing the peak. The number seems to be increasing linearly, which is some consolation. It doesn't seem to be increasing exponentially at that point, increasing to be a little slower than exponential. But we're not anywhere near seeing the peak. We're not anywhere over the peak. We're not anywhere seeing the decline in the number of cases we might have expected to see. This is important from multiple points of view, because this suggests that maybe what we have seen so far is not really the true epidemic. The true epidemic is yet to come. And the true increase in the number of cases, as you see with dense regions in Bombay, Gujarat, etc., this is really going to be the acid test for the public health system in India. Can we cope with the number of cases that is increasing, let us say, a factor of 5 or 10 beyond this number, in case we are really at the point where the epidemic takes off? and not at the point where it close to an inflection point where it begins to come down again. So with that, let me finish this talk. Let me thank you for your attention, and I'm happy to take questions at this point.
So I request people who are there to raise their hands so I can see who wants to ask a question. I will first read out a question which has come from YouTube. So can the recovery rate play a key role, and what are the chances that it will surpass the active cases, especially after the lockdown is lifted?
The answer is that it probably will not play a key role, except in terms of numbers of recovered, which the government sort of would like to advertise as a positive. But in epidemiological terms, that's not so important, that the rate at which you recover. It's more, the issue is more, can you control the rate at which people become infected?
Right.
That is the more important quantity to worry about during the period of their infection. Yeah.
Okay, so now open for questions on Zoom. Anyone has a question? I wanted to ask a question till other people come up with theirs. So now the full large-scale model that you are looking at, so in that, is that going to be agent-based through and through, or is it going to be agent-based for each district or some compartment? Or
we haven't, so the separate work, Bharat Sim, as well as the other agent-based models.
Right.
And so we haven't really begun to address what might be the way we are going to structure it if we really want to do 1.3 billion people. Right now, it's easy for us to do a city of about 10 to 12 million. We can push that up to 20 million or more without a computational problem. Whether we will have to do something, and the impression is we can push that up probably to about even 100 million without a problem. But to get from there 1.5 orders of magnitude larger is going to be a challenge. And there we might need to combine agent-based models with other types of models that don't have that level of complexity in them. To combine agent-based model with an SIR model, or maybe even some sort of field that represents the underlying susceptible infected recovered. So I've been sort of suggesting this for a while. I haven't seen this approach anywhere. That maybe there is a possibility of having some sort of combination of field and particle description, where the particle description determines the field, and the field is sort of the general SIR, and that thereby changing the properties of the particle. This seems like an interesting and very different way that a physicist might know of approaching this problem. And I think that's really worth it to think about.
I think Professor Arun Grover has a question.
Hello.
Is there data for Pakistan, Sri Lanka, Bangladesh? They have. They're like us.
The people in Pakistan who I know about are sort of very worried about all the relaxations. The tracking of cases doesn't seem to be too good. The tracking of even deaths doesn't seem to be too good. And there seems to be
what about Sri Lanka?
Sri Lanka, I think, has seen some number of cases, but I don't think it's out of control yet. And the
point is that one could compare, say, Sri Lanka with, say, south of India.
Yeah, that's possible. Yeah, that's possible.
Because then habits are similar.
I have not seen any analysis of that. But that's an interesting point. Looking at Sri Lanka
and they log data quite well, Sri Lanka.
Yeah. Correct. No, that's a good point. I haven't seen that anywhere.
Maybe you just compare.
Worth looking.
I mean, say Colombo with Bangalore.
Yeah.
Colombo with Chennai.
Yeah, good point.
Colombo with Trivandrum. So this could be an interesting comparison. This
sure,
could give
absolutely. I agree. I haven't seen that done, but that's a good point.
I think
so can something be modeled for, say, for Chandigarh, which is a tri-city, the offices are in one place, people live in, say, Mohali and Panchkula. So, so this is a kind of a tri-city where place of work, it's like, downtown. So Chandigarh city is a kind of a downtown. And these are two major suburbs.
So there the agent-based models would do very well, because they could actually, the city is not large enough that you cannot handle it with an agent. People can do Bombay, they can do Chandigarh.
Could you give some insight on, this asynchronous lockdown. This is a kind of a thing that the UT administration would be very happy because they have to take decisions on everyday basis. So if
what I can say is that the models pretty unambiguously point to the fact that that is a good thing to do. That you can change the 2 days on, 4 days off, 3 days on.
Could you run some simulation? Put in number of people in Chandigarh, say number of people in Panchkula, Mohali, and Zirakpur. Okay, and just run some simulation, because then it can guide the UT administrator as to how he should liaise with the Punjab government and Haryana government.
Sure, that's not a problem. Sure, we could do that. That's not a problem. That's certainly a good suggestion. We could do that.
Because this way
we are doing something for Pune, for looking at sort of wards in Pune to try and understand.
Your presence in Ashoka University, would help the UT administration to take some decisions which at least can be implemented in an urban area.
Sure.
And in UT, things are implementable. The political pressures are low. The bureaucracy is responsible. And most of the bureaucracy in UT Chandigarh is all engineers from IITs. Or 50% of the IAS officers are IIT engineers. So if you do that, these people will lap it up, whatever you produce.
No, that we can certainly do without a problem. We can do that.
I don't know whether I can help you to connect with some of those so that they feed in the real-time data to you and lies with you to do this.
Yeah,
I would be happy to help you in that.
Yeah.
Okay, Aru has a question. Aru Berry.
Hi, nice to talk, Gautam. I have a related question which Arun just asked. It's regarding, how we can realistic models which you explained in the end, how the connection can be done with respect to the previous model you explained in terms of the peaks.
Sorry, I missed the last few lines. Just say that again.
How can it be related to the lowering down of the curves? Stick to the realistic model you explained for Mumbai case, and when it can be expanded to all India cases, all India simulations.
So the all India case, we have not sort of begun yet. We are still trying to sort out the technical problems with that.
Yeah.
And that is a very large, it has not been attempted before at any scale in India. So it's something we still have to understand how to do. I think with the agent-based models, we can implement very micro strategies. We can say that one particular region we can shut down, one particular region we can allow people to go back to work. We can shut down certain types of rail connections, metro connections between different areas. That's the advantage of the agent-based model. You can be much more micro in the way you address the problem, rather than sort of even a very small locality within a city. You can model shutting that down, shutting local schools down.
Okay. So are there graphical representation for Mumbai case? Any graphical representation of the results?
Yes. So in fact, I think the Bangalore model, they also have a tool, an electronic tool which you can use to put in a number and see what happens. We have not made our public yet, but we do have one for our suggestion as well, which was shown in the talks in the recent online symposium that we had for a day. It just showed what our problems.
Thank you.
Yeah, so I have a question coming in from Anu Sablok, which says, why do you think the number of cases is coming down in all those countries but not in India? Is it just a matter of waiting it out, or is it something more fundamental?
Well, finally, if you wait it out, it will go up and come down. And I think the worry in India is that we are not testing enough to actually figure out what is going on in the background of the population. And figuring out and saying that, look, we're not seeing many deaths is not really a good indicator of how effective we've been, because deaths have gone down for many reasons because of the lockdown. We're not seeing traffic deaths. 100 traffic deaths account for, I guess, 150,000 odd people per year. We're not seeing many other types of deaths that could potentially have been. People are less stressed because they're at home. They're not having to commute for 2 hours a day, morning and evening. That's another possibility. And so my guess would be, if I had to guess, that we are still underestimating the number of people who are infected in our population. And the rise that we are seeing is really a consequence of that. Other countries have done a somewhat better job of getting testing out in larger scales and of course, they have smaller populations to deal with. So that's not, I mean, we have a large population. And often we have populations in very dense situations, which makes it much, much harder to control. For example, in Dharavi in Bombay.
Yeah.
So my guess would be that our numbers are going up because there is a background of people that is steadily rising that are infected, but do not turn up in but have simply not been tested. And I'm not sure how far to push that argument. There is expanded testing being contemplated every time there are more tests being done. And hopefully there will be some effect of that, figuring out where we are. But I'm sort of concerned about that.
So there's one question from YouTube Live, which is, what is your own take on how the lockdown should be lifted?
So I mean, I like this idea of the staggered lockdown of sending people back to work and coming. It will not work for every occupation. There are not, I mean, certain types of office workers you can send there and send back. Certain types of workers you can do that. So as far as you can, you should try to do that. So just so that there are fewer people mixing together. As we found out with the simulation that I showed you of the agents, the moment you expanded the regions across which people could mix, you wound up with a situation where more and more people were infected. By keeping numbers low at any given time in office spaces, workspaces, factories, by reducing it by a third, and by keeping up the same sort of stringent distancing measure that we've become used to now, there is a chance of holding that in place. Once people go back into lockdown conditions at home, it's easier to identify people who are ill, pull them out of the population, test them, make sure that they're in, and test their families as well. And we have to make that a little more acceptable and palatable to people, that this is really, you're doing this for the sake of the population. So a lot of it really now has to do with efficient and effective communication. The government has to assure people that it's on their side. It's not just a mechanical question of trying to figure out, how do we reduce this number of cases, where do we test, etc. But communities have to be encouraged that the public health system is working for them. And it's in their interest to be able to identify people who are ill in the community, get them to be tested, and then make sure that they're treated well once they're tested and they have to be quarantined. So quarantine facility should be a nice, comfortable facility that people will have no problem going to, whether rich or poor.
Right. So there's a question from one of our students. What measures should institutes which are somewhat closely knit systems, what should they take before opening? Places like IITs, ICERs, and so on, where hostels are quite densely populated, and so are classrooms.
So that's a really hard question. And I wish I knew the answer to that. I think one way that at Ashoka, I think we've taught the last several weeks, we've taught online. And for some points of view, it's not great. But I think people have got more used to that idea now. And some combination of having some people in a rotating population in class that comes there, and some population that watches this from their dorm rooms, people going to lunch across staggered hours, people just getting used to more hygiene in how they function, not getting too close. I think already you can see that people in the population, unless forced to, except to some level the need to wear masks, some level not the need not to crowd out too much. So better methods of controlling dense situations, dense crowds, I think would be good. I think the IITs you meet in the classes, you meet in the mess as well. So staggered hours for messes spread over a longer time, and an assigned time in which you go would certainly be one solution to crowding in messes. Having people combine, staying in your room and listening to a class outside would also help. But in general, more awareness of why one has to take these measures, I think, is crucial. And that's where people can, young people in institutions like yours or mine or the IITs or colleges, etc., can really help, because if they understand that this is something that they have the energy and the ability to actually communicate to the public at large, their own families, their own people around them. And that, I think, is very crucial.
So, another question from a student. In some places, the lockdown has been very successful, like Kerala. However, in other places like Maharashtra, it has not been successful. So why the difference, and what is going on here?
Again, great question. So what a disease like COVID-19 does is to expose various deficiencies in our system. The public health system in Kerala is, because successive governments have paid attention to it and the public accepts it as really being an important service, and they're comfortable with public health workers coming to their house, checking in on them, confidently comfortable. Because the public health system has a high level of trust in Kerala, that's why measures like this were successful in Kerala. And then from everything that I have heard, they just really handle this very well. Bombay has unique problems. Bombay has extremely dense areas. There is a problem of any large city, any mega city in the world. There are people who live in very dense situations. There is no way in which you can ask them to physically distance themselves from each other. And if you have very tight-knit communities, it's even more difficult to pull people out, quarantine them separately. And I suspect it's not that I doubt the abilities of the Maharashtra government and health services vis-a-vis Kerala. It's just that they have a very much more complex system to try and understand and try and work with. And some states have done well, some states have done badly. Initially, West Bengal was not doing very well in regard both testing and reporting. And now it seems to have sort of made up its mind to do better on all of these counts. I think states, individual states, because health is a state subject, individual states have to realize that it's in their best interest to do this, to report honestly, to report accurately, to follow up, to create a cadre of good public health professionals who will do this. That I think that is really crucial. And that's, as I said, this is where the fault lines in our public health system really come, where you can really see how different states compare against each other and what the effects of defunding a public health system over a long time, not funding it at consistently and at large enough scale, will actually do.
Yeah. So there is another question which I don't understand completely. Is there any model based on a sector-wise distribution, for example, the spread in medical service providers amongst construction, industry, police, and so on? So essentially, I think trying to understand what percentage of population is involved in different types of activities.
Yeah, good question. And as far as I know, no. Of course, now with the lockdown, you're not able to tell at all because all of this construction has effectively stopped. Many of these services have stopped. What's possible to do is to find out what happens to healthcare workers who've been really inundated and overloaded with the COVID-19 epidemic. It's known throughout the world that healthcare workers are the most susceptible to COVID-19 because they come closest into contact with patients who have the disease. And often the procedures such as intubation involve the release of aerosol, which are taken in, which carry a fair amount of virus inside. So they are really most at risk. Apart from that, in the general population, I don't know of any study in India. I don't know whether there are, whether beyond what is generally known, for example, school teachers are again a susceptible population in general because they encounter lots of students who carry disease with them. There are certain professions that are high contact professions that seem to be more susceptible, but I don't know of any study in India that looks at those numbers as yet.
Okay, so I think I've gone through all the questions on both YouTube Live and Zoom chat that I received. If anyone else has any questions, ask now. Okay, so I think we can all thank Gautam for this excellent talk and interaction, and for all of those who are attending. Next week, we'll have a talk by Rajesh Sundarajan from ISC, where he will talk about agent-based models. Thank you, Gautam. Thank you so much.
Thank you, Jaspreet. Bye-bye. Thanks, everyone.